Okay, chaps, so 3 cases, maximum of 10 minutes per case, no messing about. We cannot go over on time. We promised it to ourselves and to everyone else. So, first case, cardiac arrest in the pre-hospital setting. Now, you have been called to a 50-year-old in his house. His wife has heard a bang and rushed to find him on the floor of their bathroom where he was unresponsive. Now, she does say actually he's been getting some chest pain earlier in that day, but when she's found him collapsed, she's basically rung 999 and her daughter's started CPR. So, immediate basic life support ongoing. Now, that double crewed ambulance has actually arrived after just 10 minutes. They've put the pads on. One is doing compressions. The other member of staff has managed to put an eye gel down, so it is looking good.
Nice.
This patient is in refractory VF after 3 shocks. Now, at this point, a second crew's also arrived to give even more hands on scene. Now, you've arrived about 20 minutes in, and you can see good anterolateral pad placement. They're going to swap to AP if the next shock doesn't work, and basically they're all over this. They're all in control. Now, when you've arrived, you've asked, what on earth can you do to help? And they have said, can you take over that airway so they can sort out the drugs and rotate compressions? So what is going to be your plan?
Okay, nice. Well, I mean, this sounds like a really well-run arrest and certainly really well-resourced, which is great. And this is certainly a case and a situation that I'm pretty familiar with from my practice. So what am I going to do? Well, I've been asked to go to the head end of the patient and help out with airway. Great. So as I head up towards the top end of the patient, I'm definitely going to glance at the monitor, just have a look. I've been told the end tidal's 5. I just want to probably confirm that and just have a look at the waveform just to see if it's a nice square waveform telling us that we've got no leaks, or if it's a sort of a slightly odd looking shape, then we might be a wee bit more concerned. And then when I get to the top end and I have a chat with the person who's already there, squeezing the bag with the eye gel in, and I just start out with a nice open question, to be honest, just something like, how's it going? How are you getting on with the airway? Have you got any concerns? Something like that. That then enables them to say, oh yeah, actually, I think there might be a bit of a leak, or, oh, I've had to do a bit of suctioning because I think there was some regurgitation. So that can kind of target your initial actions, can't it? And realistically, if there's no concerns that are raised at that point, I just want to have a quick whiz through and think about how efficacious is this eye gel? Is it working really well? Simple things. Can I hear any leak? How does the bag feel? Is the chest rising and falling nicely and symmetrically in a good amount? Stuff like that. And then if it is working well, that's fantastic. That means there is no rush to move on and think about having to either upgrade the eye gel to a tube or to change the eye gel for a different size or to sort of reseat it. And so in this case, it sounds like the eye gel is working really well, which is fantastic. That means we can just take a step back. We can kind of slow things down. Admittedly, this is a cardiac arrest. I don't mean we're going to, properly just sit back and have a sandwich, but, we're not going to...
Not near the toilet, anyway.
Oh, yeah, I forgot we're in the bathroom. Yeah. I mean, it might be clean. But we're not going to have to rush into doing anything with this airway, which is great news. And so I think realistically, the next decision to make is the trajectory of this patient. And what I mean by that is where's this patient going? What do we expect this patient to do? And, this is a 50-year-old arrest with early bystander CPR with refractory VF. So the hope and the anticipation is that this patient is going to get a return of circulation, although he's now been in arrest for a while. So the likelihood is that if we do get a ROSC, he's not just going to suddenly magically come back to GCS 15. So I think personally, this sounds like a patient that will require an intubation potentially to manage his ROS down the line. And I say that because actually if we do the intubation during the arrest, that means we can save a bit of time and be more efficient on scene because we're not having to kind of slow things down once we've got a return of circulation to do our pre-hospital anaesthetic. So that means we're going to start getting our stuff together for our intubation. And that means I'm going to need an operator 2 or an assistant. So, Simon.
Hello.
Hello, mate. So, Simon, I think this patient needs an intubation because of his trajectory. The eye gel's working really well, but I'd like to get a tube down in case we get a ROS. So would you be able to help me out as my operator 2?
Thank you very much for inviting me to the party, James. Well, it's very good of you to include me in it. But whilst you've been doing that, I've sort of been anticipating that might be the case. So,
perfect.
Yeah, I'm very proactive. So I've been looking round at the environment, and this is really important, as we've covered earlier, because having the space to be able to manage that airway whilst not compromising all of the other really important stuff that's going on is really important. So again, without really interrupting any of the chest compressions, sometimes a little drag into the center of the bathroom, maybe putting the legs up in the air to create some more space, is something that can make a massive difference to things. Now, I think we're in the upstairs bathroom, so I've probably had a little look through to the bedrooms as well and had a look for a pillow, because positioning in cardiac arrest is massively important and it's something that we can so easily overlook. So I'm trying to anticipate what you're going to do next and make it as easy as possible for you. I'm not commenting on your technical performance. I just want to make sure that we've really set stuff up as well as we possibly can do. So optimizing the environment as best we can, knowing that we need to concentrate on the other factors going on in the cardiac arrest, and getting the positioning sorted. And then I guess we're going to have a quick chat about the sort of equipment we're going to be using. So I'll be asking you whether or not you want a VL or a DL.
Yeah, and that's great. And that is a perfect example of a great operator too. You've been doing all of that totally unbeknownst to me whilst I've been kind of heads in and assessing the airway. So great stuff. I'm very glad I selected you, Simon, to be my assistant.
The lucky one.
I know. So fantastic stuff, and I totally agree. You know, we've got time to position this patient well. There's a real temptation, isn't there, sometimes to rush into doing this, and so still maintaining that ear to sternal notch positioning, the face level with the plane of the ceiling, and all of that stuff we've talked about before is really vital. Now, you asked me about what I was going to use. I think a video laryngoscope would be really appropriate for this patient. We are on the floor, which is automatically going to make this a bit more challenging, and the positioning, you know, potentially a bit more difficult. And so a video laryngoscope is going to help us with some of those difficulties. But there's been an eye gel in for a little while now, hasn't there? So there might be some secretions around. And so I'm going to be anticipating that. And I don't want to plunge my VL into that and obscure my view with contamination all over the camera. And so definitely going to need some suction set up. If that hasn't already been done, I'm sure it has, Simon. And when it comes to the intubation, I'm going to be 100% keeping the video laryngoscope blade high in the mouth, and I'm going to be leading with the suction to make sure that we get a nice clear view of the glottis. And while we're at it, I'll need that bougie as well.
Excellent. Well, you'll be glad to know that I got all of that ready for you, and there are a couple of suction units to hand just in case one of them fails. I've also got out our shadow board, which we've got just to make sure that we've got all the kit, and I've tested it, and I'm here at your beck and call. I've also, because I'm in that operator 2 position, I've had a really good chance to have a look at the airway and assess it from the sidelines, because as you've said, we're trying to position really well, and it's a great opportunity to do that. So everything's ready. We'll have a chat with the team, won't we, and make sure that we really don't distract them from what they're doing. And essentially, we're given permission to intubate this patient as and when they'd like us to do that.
Oh, sickeningly good performance there, gentlemen. Lovely. Is there, after you've confirmed that tube placement, is there anything else you want to do, or is that it all? Time to wrap up and go home?
Well, I haven't let James take the blade out of the mouth, because into his field of vision is going to come an orogastric tube. Because again, from that operator 2 position, I've got a really good look at this patient and seen that, understandably, with the ventilation that he's been getting for the last 20 minutes or so, he's got a bit of abdominal distension. And in order to increase that venous return, if we can alleviate the distension of the stomach, then that might just help us get that ROSC that we need.
Okay, lovely. Well, let's draw that pre-hospital case to a close, and let's bring things back into the hospital for case number 2. So, gentlemen, you are both working in an ED. God forbid, the poor public.
This has really happened.
Yeah, I don't know who does the rotoring at this hospital. But you get a call from me that's a couple of minutes away from hospital with a 40-year-old male who was on his push bike coming downhill, not wearing a helmet, and he has gone over the handlebars and gone face first into the tarmac. Now, when we arrived, it was reported by bystanders that he'd had a loss of consciousness for a couple of minutes, but when we got there, he was starting to wake up. A little bit confused, but then returned to a GCS of 15 after probably about 10 minutes or so, and complaining of some fairly significant neck pain. So with that mechanism and with his complaints, we've collared and blocked him and we're bringing him to ED initially under normal conditions. But actually, I'm just giving you a call back because he then started fitting. So we've pulled over, given him some benzos. That stopped the fitting, but my goodness, he's very agitated right now. I think he might have aspirated during that seizure, and he's got a degree of trismus. So we're really struggling with the airway, and we're just now a couple of minutes away. So how would you like to approach this challenging patient?
A few minutes longer would have been nice, James, next time. Just do a lap round the block, would you, and then bring him in. Well, I think this is one of those cases that, you'll see fairly frequently in the emergency department, and you've got to have the resources around you. So I think it's great that Simon's on because he's a very good clinician. So what I think I'd do, I'd take over the team leadership role in this case and send Simon up to the head end, so with his newfound airway skills that he's got. So I think with the couple of minutes that we've got before this patient comes in, it's really important to brief our team, make sure that we've got enough resources in our resus room, and make sure that we've got all of our kit established as well. I think there needs to be some really clear communication early on and prior to the patient arriving with your airway clinician or your anaesthetic team about what the needs of this patient are likely to be. So specifically here, you can see he's got some really clear indications for a rapid sequence induction of anaesthesia. So first of all, he's got a reduced GCS following a head injury, and he's got the potential for aspiration, and we're going to need to get him through some imaging. So the indications are just racking up and up and up. So this patient is definitely someone that, unless everything's settled right down, we're going to be looking to provide a RSI reasonably soonish after the patient arrives. But of course, we're going to need to spend some time optimizing as much as we can with those patient factors.
So I think that's a really nice introduction, and you're absolutely right. These patients can be very challenging to optimize before we go down the RSI route. So what are your thoughts around that? How are you going to ensure that you can optimize this patient's physiology before we move to the anesthetic?
Yeah, that's a really good point, James. We do need to absolutely maximise the physiology, but I think the team leader responsibility here is maintaining oversight on that whole case. So I think with regard to the specifics around how we're going to manage that actual case, we can delegate that to our anaesthetic or to our airway clinicians whilst we try and manage the other elements. So Simon Lang, it's your time to shine.
The other elements? What do you mean? This is all that's going on here. You've got very slopey shoulders today, Rob.
We're very much focusing on the airway, but my goodness, this case comes with a whole lot of other stuff to do.
All right, okay. Well, again, similar to the cardiac arrest in a pre-hospital environment, there are a lot of themes to what we're going to be concentrating on here and a lot of similarities. So I guess normally I'd be working with a colleague, so it would be pretty normal to expect that a couple of people might have come down from anaesthetics. There might be an ODP, there might be somebody in resus that's able to give me a hand. So ensuring and anticipating that this is going to be difficult to manage even before you're there, making sure I've got all the kit for the airway ladder, making sure they've got a video laryngoscope to hand, making sure that the ventilator's working. If I can give that to somebody else to do, then that gives me a chance to concentrate on the pharmacology. So if we've got somebody like this that isn't going to comply with a good amount of pre-oxygenation, if we are going to go down the RSI route, then having some ketamine, because thinking about that delayed sequence intubation that we mentioned earlier on, this is going to be a perfect candidate to get a dose of ketamine beforehand. Maybe 20, maybe 40 milligrams of ketamine IV if we can, to see whether or not we can then get them still, get all the bits that we need on, and then really perform this in a calm environment. We're also talking here, aren't we, about the patient with a head injury. And when we go back to those tables of those standard recipes, this is one of those patients that I'm guessing is going to be quite hypertensive if they've got a bleed in their head, that is, as we've said, in need of quite an anaesthetic because they are agitated. They're certainly not obtunded. So this strikes me as somebody that we're going to be thinking in the region of a 3-2-1 with regards fentanyl, ketamine and rocuronium. So those things all take a little bit of time to be drawn up. So I'm probably going to get those to hand and get them ready.
So nice. So I guess there you're talking about giving this patient some sedation to manage their physiology. And one of those aspects is the pre-oxygenation, isn't it? So I suppose we know that in these traumatic brain injured patients, a single episode of either hypotension or hypoxia can be really bad for them. So this will be a case, no doubt, that you're going to put some apneic oxygenation on as well.
I mean, that wasn't really a question, was it? You were just telling us in case we didn't mention it.
It was a prompt because I thought you'd forgotten. And actually, while I've got your ear, I just want to just make sure, Rob, that you did hear in my handover, I was pretty concerned about this guy's neck, both from the mechanism and his complaints of pain to the C-spine. So is that going to affect any of your plan going forward?
In short, of course, it's going to affect our planning. The reason being that whilst we've got a patient here, there is evidence or clinical concern regarding C-spine fracture, and we know, or we don't want to make that any worse. Although we clearly are aware that the time of injury is when we're most concerned about the most movement. However, what we are going to be doing is we're essentially going to be rendering that patient unconscious, and of course, all of those protective mechanisms that might have been there before, and I do say might, will disappear. So we need to be really cautious with this patient's C-spine. And of course, manipulating the airway is not going to be something that comes without some degree of movement. Now, the other thing we need to be careful of with this, though, is that actually what is it that we're going to do to keep this patient's head and neck as still as possible? And how is that going to impair our ability to pass the tube and then oxygenate and ventilate them? Because, we have an absolute risk of that patient having a more difficult airway versus a potential risk of a C-spine injury. So I would say that we would have to keep that patient with some degree of immobilization. So something like some manual inline stabilization. But the good thing with this is that we can release that collar off. So therefore it might improve our mouth opening and our view that we might get. And we just need to be aware that actually, if we do run into difficulty during intubation, it might be something that we do have to manipulate in terms of move that position to optimize that better, if that makes sense.
Yeah, and in terms of the intubation itself, again, setting the scene and setting the room is so important here. We've shown pictures in the course of the video laryngoscope having a screen on the top of it, but very often in emergency departments, to save people nicking them, they actually have the screen mounted on a trolley. And it's really important, I think, when you're setting up that environment, that you get the screen in. And again, it's in line with where you're going to be taking that view with that video laryngoscope, where you're going to be putting the blade in again, so you don't have to rotate round. In terms of what we'll be using, again, seems like we're banging one drum here, but this is going to be a video laryngoscope, again, to improve that look around the corner without having to manipulate the anatomy too much of that neck. This is going to be a bougie. It's going to be suction ahead, and I'm going to be verbalising what I find back to the whole team. When we talked about those 30-second drills beforehand, I said that it didn't matter whether or not head lift came first or external laryngeal manipulation did. But this is really going to be a great case to aim, if we're having a difficult view, to provide external laryngeal manipulation, because then we're not going to be altering the alignment of the C-spine. And it also might be one of those that operator 2 may either offer to, or I specifically ask them to give a jaw thrust, again, if we're having difficulty getting that blade in and having a good look down. So that's probably going to be the tweak that we're going to be making sort of with laryngoscopy and with this RSI. Now, I think we've stuck to time pretty well here, and it's being an incredibly busy shift amongst the three of us. So it's time for me to sit back really and have a cup of tea, because it's time for the last of the three cases going to you two. So you're now going to make up a team looking after a burns patient, and that's going to be made up by standard road crew, and you guys are going to be there in a critical care team. And the patient has been really badly injured. It's a 30-year-old female. She was sadly trapped in the room of a house that's been on fire, and she's got very significant burns. So she's had loads of smoke exposure and direct burns, covering about 50% of her body. Now, she's barely conscious. In fact, she's stridulous and she's hypoxic. She's been taken out of the house. Now she's lying on the floor and being attended to by you all as a team. And as we said, she is hypoxic. Sats are sort of at best high 70s, low 80s. Blood pressure is about 150/80. Heart rate's 130. Resp rate, although seems okay as a rate, is about 20, but it's got really poor tidal volumes. So that's your case. It's got a lot of challenges. And what would be really great if you could just chat through what you think you're going to do with this patient and really how you're going to plan and bring everyone together for it.
Yeah, wow. I mean, really interesting case and pretty full-on case. And I think the important thing with this is that the plan is going to be exactly the same. And hopefully that message has got across over the course of this course. That's a double course. But hopefully you've got the message now that actually the plan is no different. It's going to be the same, but it's about adapting and considering that plan for each individual patient and situation you're in. And for me, the key section for this patient is thinking about preparing to fail and what is our plan around the challenges that this airway is going to present to us. And again, I would follow our standard approach, but just thinking about the specific considerations for this patient. So I would think about, how do I prepare the patient? How do I prepare the equipment? And how do I prepare the team to manage this very difficult airway? Okay, so I'm going to head up to the airway and start managing things and temporizing the situation as best I can. Rob, do you want to come in and start prepping this patient?
Yeah, absolutely, mate. I mean, I think like you've alluded to, we need to keep this same structure that we've got for everyone, but this is around planning for failure. Now, in this particular case here, we've got some big challenges. So we've got some case-based challenges. We're almost certainly going to have some anatomical challenges caused by that burn, and we've got some physiological challenges as well, because saturations of 70, 80%, and who knows how much of that is carbon monoxide rather than oxygen on that SATS probe. So it's going to be really difficult. So from a patient preparation perspective, I think we really are going to need to focus on optimizing our oxygenation as much as possible prior to this intubation attempt. So we're going to be thinking about making sure that patient's getting 15 litres of oxygen, or as much oxygen as we can provide, via a well-fitting face mask with a reservoir, and also apneic oxygenation, so 15 litres going through those nasal specs at the same time for ideally 3 minutes, as much as possible. The next thing it's going to be is that we're going to need to have absolutely impeccable attention to detail regarding our positioning of that patient, because you want everything possible within your favour, because this is going to be challenging, as we've said. So yeah, make sure that patient's oxygenated well, make sure we've got that patient in the correct position, and we've got 360 degree access and all of those factors controlled that we can control.
Yeah, I totally agree. And I think the other thing for me on a patient preparation perspective is that I'm up the top end while you're kind of busying yourself with getting this patient into the right position. I think if I've got some spare hands, or if somebody else is available and there is some time, sometimes these patients present and actually there's very limited time, and actually you really need to push on and be efficient with your processes, don't you? But if there is time to put a bit of thought and planning into this patient, then I would think about marking up the cricothyroid membrane, identifying it, getting a marker pen, marking it onto the skin where you're going to do your incision. Because by doing that, you're not only offloading some of the cognitive decision making, because you've already sort of taken that step mentally to say this is a possibility, but also you're going to minimize the time it's going to take to do your front of neck access, because you've already identified the right access point of the anatomy. And I guess while we're on that, I would, rather than having the front of neck access kit just kind of lying around and in the bag where you might normally leave it, I'd probably stick it on the patient's chest too. Again, minimizing the time to get to it, but also serving as a reminder that here is the front of neck access kit. This is something you might need.
Yeah, I think that's a really good thought, really good idea, having that there. As I say, the cricothyroid membrane marked, ready to go with that kit right in front of you, in eyesight of the whole team. Really good, yeah, from a human factors perspective as well.
So I guess whilst we're on equipment, other things that I'd be thinking about that I might adapt on my kit dump. Normally, we've talked before about putting a tube out for the size that you anticipate and a size smaller. I would probably go a step further, and I'd say I'd probably have 2 sizes smaller, because you've already said, Rob, there is the potential for there to be some pretty significant swelling and developing edema in the airway. And so when we get in there might be a good view, but it might be that the glottic opening is really narrowed. And so if you're expecting to use a size 7, it might be the only tube size you can get in as a 5. And actually, you don't want to be ferreting around trying to find that in the middle of this difficult airway. So I would lay out a size below what you want, and potentially even 2 sizes below on your kit dump.
And just to finish this cases section off, what about in terms of the brief and the plan that you're going to have with your team here? What guidance are you going to be using, or what framework?
Yeah, and I think that's a really good question, because it's super important that we cover off all of these aspects. We've prepared the patient, we've prepared our equipment, and it's vital that we prepare the team in any intubation, but certainly in one as challenging as this. And so I think, first of all, we need to be really clear with the team leader, because we need to have that nice closed loop communication and make sure that the team leader is still dialed into all of the decision making so that they've got that overview of the situation. And we need to be very clear with them that this has the potential to be a difficult intubation. And then we need to follow that up with the idea of our airway plan. Now, it doesn't matter what airway plan you want to follow, but you need to think it through. What's going to be best for this patient? Do I want to follow something linear like the Difficult Airway Society, or do I want to use something like the Vortex approach, which is a bit more sort of individualized to the patient? Personally, I would probably use the Vortex approach for this patient, because I think if you go in and you have a difficult or failed intubation because of either anatomy or swelling or challenging view because of, tongue edema or something, then I think it's unlikely that placing a supraglottic is going to be helpful in this case. And so I think by using the Vortex, you can be a bit more selective over the lifelines that you use. But whatever you choose for your airway plan, certainly you and your operator 2/assistant needs to be on board with what that plan is, but you need to verbalize that to the whole team so everybody's on board. I think we also need to think about who is going to take the intubation. And I think this isn't the time to be getting up the numbers in your logbook. This is definitely...
Nope, I'd agree with that.
This is definitely a case for the most experienced intubator. But there's also some challenges, aren't there, too? Because operator 2, who's standing on the right-hand side of the patient, is probably going to be the one to do the front of neck access if necessary. And we just need to check their level of comfort with doing the front of neck access, because we don't want to expect them to be doing it and then suddenly when you call upon them, then they're slightly reluctant and unsure of the technique. So we need to be on board with what your plan is, what everyone's roles are, so that if things go wrong, we can implement that plan without delay.